Well, my name's Ali, and I am an F2 working in Portsmouth at the moment. I'm going to be talking to you guys about esophageal cancer. Most of the things I'm going to say are already included in the slides, but I'll try and talk through some of the more difficult concepts. Let's start. So, I've included quite a lot of detail in these slides. It's by no means necessary to learn everything written down. It's more for those interested in surgery or aiming to do well in their exams. But if you do stick with it, you'll have a very good, solid foundation for esophageal cancer. So, before we start, I'm just going to say how important it is to learn things in terms of classifications. This is important, especially in OSCEs and oral examinations, and it'll be appropriate for you for the rest of your career. For example, if someone asks you how you investigate for cancer, you don't just say, I'm going to do an MRI straight away. You'd start with bedside examinations, bloods, imaging, and then move on to invasive procedures such as biopsy. I've set out the slides in this way where appropriate, so hopefully it'll help you with your learning. So before we start into esophageal cancer itself, we're going to talk about some definitions. Now, it's absolutely key that you know these definitions off the top of your head, so when asked in an exam, you can say them without having to pause or think about it. So these are all related to cancer, and especially in a cancer pathway associated with adenocarcinoma, specifically of the esophagus. First one is metaplasia. So metaplasia is a change from one cell type to another, and it's reversible, which is a very important thing. So for example, in terms of the esophagus, the lining of the distal esophagus gets changed from squamous epithelia to columnar. Dysplasia is one step above metaplasia, so it's a reversible change in cell type with abnormal cellular architecture. So what this means is there's precancerous changes within the cell. The cell itself is resembling cancer, it's changed type, but it's not malignant yet and it's not irreversible. Finally, the last stage is neoplasia. This is irreversible and it's cancer. It's uncontrolled proliferation of cells with the cancer architecture and it's not under physiological control. Finally, the two types of cancer we'll be looking at: carcinoma, cancer of squamous epithelia, and adenocarcinoma, cancer of glandular cells. Here's some epidemiology in the slides. You can have a read of that yourself. The important thing to know about esophageal cancer is it presents late, metastasizes early, and is a very aggressive cancer with poor survival rates. So there's two main types of esophageal cancer. One, and the most common one, is squamous cell cancer, which typically affects the proximal two-thirds of the esophagus, and then adenocarcinoma, which is the one you hear about, which is related to Barrett's. This affects the distal one-third and also the gastroesophageal junction. There's other rare types, but you don't really have to know about those. So we're going to start by talking about Barrett's esophagus and adenocarcinoma. So the incidence of this is increasing, especially in the Western Hemisphere, and this is mainly due to the Western diet. The prevalence of adenocarcinoma is greater in the Western than the Eastern hemispheres. Before we can learn more about adenocarcinoma, we need to learn about Barrett's esophagus. Barrett's esophagus, also known as Barrett's metaplasia, is a pre-malignant condition of the distal esophagus characterized by conversion of typical squamous epithelia into atypical metaplastic columnar epithelia. So if you whip this definition out in an exam, the examiner is going to be like, whoa, this fella knows what he's talking about. Anyway, it's important because it's the precursor before the development of adenocarcinoma. And lucky for us, the exact etiology is not understood. But basically, acid exposure induces an inflammatory response and causes a change from squamous to columnar cells. And as acid reflux affects the distal esophagus, Barrett's also affects the distal esophagus, and thus adenocarcinoma affects the distal esophagus. So the risk factors for adenocarcinoma is mainly Barrett's esophagus. Barrett's esophagus is a condition I'll explain more about in the following slides, but the risk factors for this is excess acid. So if you're sitting in an exam situation and the examiner asks you what are the risk factors for Barrett's esophagus, you'd classify them like I mentioned earlier. So you'd say excess acid. This can be from GORD, it can be secondary to infection, for example, H. pylori, and then you wouldn't really mention Zollinger Ellison unless you want to be questioned on it, but you could say other conditions. Other risk factors would be patient factors such as age or the being male, the patient's social history such as smoking, obesity, or a diet low in fruit and veg, and then genetic, so familial Barrett's. Right, so the metaplasia, dysplasia, neoplasia pathway is something you hear examiners going about all the time. It basically just goes back to the definition we talked about earlier. So if metaplasia is not controlled or kept in check, it can progress to dysplasia, and if that's not controlled, it can progress to neoplasia. That's all you need to know. Squamous cell cancer, most prevalent cancer worldwide in terms of the esophagus, much more common in the Eastern Hemisphere. So the examiner asks you, what are the risk factors for squamous cell cancer of the esophagus? You take a deep breath and classify them. Patient factors, age, male. Social factors, smoking, alcohol, a diet low in fruit and veg, high in spicy foods, and high in saturated fats and meats. There's also potential risk with drinking hot beverages, so if you're sipping a cup of coffee right now, maybe switch to water. Finally, there's a genetic link, so family history. I've included some conditions that you do not need to know and you definitely should not mention. It's just an example of what genetic conditions are associated with it. So, how does esophageal cancer present? So, the absolute alarm bells ringing signs should be progressive dysphagia. So that's difficulty swallowing. That starts with difficulty swallowing solids and then progresses to liquids over time. And that's as the cancer gets larger and compresses the lumen. And the other one is weight loss. If this presents late, they can also be cachectic. Less common signs, but signs to be aware of are B symptoms, so fever, lethargy, appetite loss, night sweats. Retrosternal chest pain, that's from the food, having difficulty passing down past the obstruction. Melena and hematemesis if there's any upper GI bleed from the cancer, and then regurgitation. So the take-home points. The most important things are to learn definitions smoothly, so you don't pause, you don't think, and you can remember them for the rest of your life. The next thing is to revise things in terms of classifications. This includes causes, investigations, and management. The last and most important thing is to be confident in yourself. Take a deep breath in. Try not to sound too boring like I am right now, and you'll be grand. The take-home points for esophageal cancer specifically. So it presents late and has a poor prognosis. It's good to note the differences between adenocarcinoma and SCC, namely Barrett's esophagus, and remember that management is guided by staging and grading, alongside patient factors. Thank you. Hope this was somewhat useful for you. If you do have any questions, please do feel free to email me. And if you have any feedback, that would also be appreciated.